all. Thanks so much for watching Making Healthcare Work for You, Different Perspectives and Empowering Solutions. I'm Stephanie Fields, joined by my co-host, Dr. Apoorv Gupta. And today we welcome Matt McBride, who is the CEO and co-founder of Mend. Thank you so much for being here, Matt.
Yeah, great to be here. Looking forward to it.
And first, I'll address the elephant in the room that my voice is terrible. This is actually the best it's been in a week, but it does not sound great. Matt, why don't you tell us a little bit about Mend? Because it's an interesting story. You started this in 2014 with 3 of your friends, and 2014 was well before the pandemic, well before people were even really thinking about telemedicine overall. And you created this as a solution for healthcare systems, but as a hybrid portal that's serving patients. So why don't you tell us a little bit about what you guys do, why you have that thought to do that 6 years before the pandemic started, and then maybe some of the exciting things you're working on.
Yeah, so my friends and I come from healthcare backgrounds, and I think we could see all of these other industries changing. So, you could start to tap, a swipe, click for anything, and things just, show up at your house for, rides, food, products, whatever. But healthcare was still very much paper, phone, fax. So it seemed like this was really going to change, and this was going to become more of a modern experience. And we were also really fascinated with the idea of telehealth and what that could potentially do to increase access to care. But we knew in-person visits were going to be important as well. So we built software that we sell to healthcare organizations, where they can brand it and sort of bolt it on and have a complete patient engagement platform that supports hybrid care. So what does that mean? We have built everything from the ground up to think about virtual visits, in-person visits, maybe asynchronous visits. We also work with in-person visits and phone visits. So, any type of appointment, it doesn't matter. And then we do everything from patient self-scheduling. The forms are all digital and really easy, convenient to do. Reminders for appointments, your payments ahead of time if we need to. And then we can actually facilitate the visit itself, whether that be through telehealth, and then any of the follow-ups that might need to happen after the visit, from surveys, maybe additional payments that are needed. So all of these touch points now become more modern. Book your appointment online, to doing forms digitally, having your appointment through telehealth, so on and so forth. So Mend is really a complete patient engagement platform that was really built from the ground up with hybrid care in mind, virtual and in-person care combined.
I'm finding this really interesting, Matt. And at the same time, I'm sure our audience members are still thinking, there's so much telehealth out there, and we hear about it all the time. And so isn't it already happening? Aren't all health systems already using telehealth to some extent? So really, what creates the opportunity at this point? As Stephanie said, folks started off well before the pandemic, but during the pandemic, we saw every health system adopt some form of telehealth solution or the other. So as you're approaching potential customers, are you trying to get them to switch to Mend? Are there still health systems out there that are not using telehealth? And what is it ultimately that helps differentiate Mend from other solutions that are out there?
Yeah, well, I think the pandemic created a little bit of a wild west type scenario. The government sort of quickly said, all right, we're going to do telehealth, and we're going to do phone calls. And you know what? You can use something that's not secure, not HIPAA compliant. So you still have a lot of that out there. So I think organizations, if the pandemic was spiking in the area, they try to move as much as they can to telehealth, and then it calms down, and they maybe start to move back to in person. And then you've got groups that just quickly threw something together. Groups that are maybe using FaceTime and these things that are not HIPAA compliant. And I think a lot of these organizations are trying to figure out, what do we do for the long term? Because a lot of the regulations aren't exactly set in stone yet. So I think a lot of people just kind of rushed and put stuff together, and they're thinking, all right, well, what do we need to position ourselves for the long term? And I think a platform like ours is going to be, enterprise grade and really position for any type of workflow that might be needed, whether you want to do on demand telehealth, if you want to do scheduled visits, if you want to do group visits, maybe even asynchronous. I think we can support a more robust strategy than where a lot of people settled, where they just kind of, threw everything together as quickly as they could.
I'm going to get into the asynchronous visits a little bit. We had a really interesting pre-interview conversation about that we all wanted to continue. And now I'm wondering, when you were saying before how you serve diverse populations of everybody from homeless people to people who are in foster care, which was an interesting need that, I never really thought of, that you have a lot of situations with mental health that come up in the moment that you need somebody then, and you can't just get an appointment, as we all know, during the pandemic. And then, so how does that work? How does the asynchronous work, and how do you still serve some of these diverse populations who might be challenged with technology? Because it sounds like the asynchronous visits may be a good opportunity for them, because they're not necessarily somewhere where they can rely on transportation or, even technology, really. Maybe they don't always have access to a phone. So how does that all play together?
Yeah. So I think, we saw very early on that underserved populations were definitely having a big impact for increasing access for telehealth. So I think every healthcare organization is trying to work within the boundaries of reimbursement, right? So before the pandemic, a lot of people don't know, you had to go into a physical location. The provider could be remote. We were starting to see states allowing patients to be at home. This is what changed in the pandemic. The government finally said, okay, if you're a patient, you can be at home, and we'll reimburse for that. So we were really working with a lot of pioneers in states that were Medicaid. Medicaid was starting to open up and say, patient can be at home. And so that for us became, maybe foster homes, different shelters for battered families where they, you can't really leave and go to a doctor's office in some of these situations. So we started working with groups that were really starting to provide care to those people, homeless folks and other types of, and of course, other types of populations as well. But we quickly found that every time somebody had this assumption that, no, it's just not going to work for that group, we're always proven wrong. So age hasn't mattered, income level hasn't mattered, all of those things haven't mattered, and we're able to provide care. Even think of crisis care, some of these traumatic events that happen around the country. We have customers that provide crisis care, mental health services when some of these terrible events that happen. So there's all these scenarios that nobody ever imagined. So we saw that early on, and I think now the opportunities have really expanded because of the pandemic. And so video is now supported for reimbursement, but what's going to be next? Where does this, the Pandora's box has been opened, the genie's out of the bottle. Where is this going next? Asynchronous could be a way to address that. So we think of that, I think, in two ways. You sort of have secure two-way messaging, where maybe you're messaging somebody in the staff that, you're trying to book an appointment. Maybe you need to get a doctor's note. You have a question, whatever. So there's sort of the administrative side to it, maybe a question about your bill. And then you also have, well, how could asynchronous, how could messaging maybe become an actual visit where all of the care is provided through secure messaging?
Okay, you called it Pandora's box, and I thought of a question while you were talking. You said, or maybe it was the pre-conversation, but we were saying how a lot of times it's the staff that's answering questions. And so if email secure messaging becomes billable and I'm not getting an email from the doctor, I'm going to be livid. Because if I go and I make a doctor appointment, that doctor is going to walk in that room. It's not just going to be the nurse and the doctor's, going to pass in the hall, be like, have a happy Thanksgiving, whatever. No, that doctor walks in that room So if I'm going to send a two-way message, how can we be sure that you're actually getting billed for the doctor writing that message?
And I think there's a lot that's, there's certainly things that physicians can delegate, and then it's documented that they have delegated that, but ultimately they're the ones licensed to provide the care. So they're responsible at the state level, they're licensed the DEA level to prescribe. So I mean, I think at the end of the day, the providers are going to definitely be providing the care. There's some things that they may delegate. And I don't think we should think of this as, well, if I send a one message, am I going to be billed and get some ridiculous bill? I like to think of maybe an asynchronous encounter as a series of messages. So a whole conversation, just like if you walked in and you're in an exam room and the provider comes in and there's a whole conversation that's happening. There's information that's provided, vitals that are provided. I think that's going to become a part of this. You're providing information verbally through documentation. There may be labs that are ordered or other diagnostics. I like to think of it in terms of a complete encounter. So not just, I send this one email, am I going to be charged? There's going to be a complete visit. And I think, doctors are doing a lot of work for free with these types of messaging and other types of visits that are happening. And the average provider is spending 4 hours outside of normal working hours on administrative tasks. So I think there's a number of different problems, from burnout, patient access, no-shows, that something asynchronous has the ability to help solve some of these big systemic issues in healthcare right now.
But then does it cause them to have, does it either, if they're then accounting this as a visit, are they going to have less actual, is that going to be a time block on their calendar? That's, okay, we got to check that off. Or if they're doing it at extended hours, could it lead to additional burnout? And then as a side note, if it's going to be an extended back and forth, which makes more sense, it seems like maybe there needs to be a checkbox for disclaimer. This is going to be, a multiple email exchange. In exchange for medical diagnosis, this will be a billed visit, something so that the patient knows that this could result in a bill.
Yeah, I like to think of it as maybe you're answering some questions to sort of get some idea of what is going on. And these questions are maybe based on a clinical protocol, right? So, okay, what this person is telling us, you go to, maybe you should call 911, or you definitely need to come in person, or this, you can have telehealth as an option. You can have a messaging visit as an option. So I think a lot of it is going to sort of originate from a clinical protocol. And then I think, ultimately the patient would be initiating it. So you've got some problem that you need help with, and we're making a messaging visit available to you, and it's going to be X dollars, or, it's going to be billable in insurance. But that's the big question right now. There really isn't, aren't great reimbursement models unless you're, doing radiology or some other imaging work and billing for that asynchronously. So I think a lot of this is unknown, but I think there's a potential there for sure.
Yeah, definitely. I think it's a fascinating conversation just between the two of you to understand, how to tease this out, because Matt, as you said, there's a lot to be worked out. I think the interesting thing about asynchronous is that we're all doing it right now when we communicate with each other, right? I mean, we have such an expectation that's email or text messaging. Of course, some of us have an expectation that those things are going to be answered right away, but it's still not immediate, and it's still not back and forth continuously. It's some discontinuity factor is there, and I think that's the way we live our lives. So why shouldn't that be a part of how we interact with healthcare as well. To some extent, I find that to be really intriguing. The other point, Matt, that I think you made that, I was also thinking about is if you can structure the interaction in a little way, maybe that answers Stephanie's question as well. Their doctors in general need to get a certain amount of information from the patient so that they can figure out what's going on. But right now, if I just send as a patient an inquiry into the doctor, it'll probably have very limited information. It might just be, I'm experiencing this issue, let me know, what needs to be done. And therefore a nurse or an assistant in the office could probably look at it and try to triage it. But if we were to follow a protocol, we probably could, structure it in such a way that you could describe your symptoms more clearly. When did they start? What makes them better? What makes them worse? And kind of like, what's their intensity? Are you taking any medication? So it's some form of a structured interview process that all doctors learn anyway, and they guide their patients through, except we'd never really usually put it in front of the patient. So maybe we start having our patients a little bit trained in thinking and responding this way. And I like what you had to say about maybe that's the basis of generating that initial report. So I guess I'm not really framing a question there, but more chiming in with my thoughts on how asynchronous could work. I also find it intriguing that you could do asynchronous video, because I think that some people, it's a little interesting to think about, but people do appreciate video interactions. And if the patient recorded themselves on video and following the same protocol and sent it to the doctor, and the doctor recorded the video and sent it back, that could add a different dimension of intervention. So I guess I won't try to tie together all these points I just made, but Matt, do you have any comments about any of the things I'm saying and how they come together to help?
I'm going to interrupt for a minute and say, I love your idea of, talking about the video. One other benefit of that is that, one, it does feel more billable, but two, if it's something that could be saved, it's something that, when you're caught up in medical conversations, you don't always remember everything in the moment. But if it was something that was on video, you'd be able to save it. That brings in another reason why MEND is so important, because it is HIPAA compliant. Because if you're then getting into video symptoms and talking about these things, you need to make sure you're going to have a HIPAA compliant platform that so many people, as you said in our pre-interview, used during the pandemic and didn't even realize that it wasn't typically authorized. It was just an emergency exception.
I'd say think of it like this, right? There are all these different steps in the process if you wanted to see your provider today in person, right? And so you might have to fill out paperwork. You might have to provide something around the payment. You go in, they're going to check your vitals. You're going to have a conversation with the provider at some point. They're maybe going to order lab results. Then maybe you're going to check out and handle any follow-up items. These things, I like to think of these things as we replicate them in more of a digital environment. So even from telehealth, for example, we have organizations where we can sort of queue and transfer, right? You might meet with the front desk person. Then they might transfer you to a nurse or MA. Then maybe they transfer you to, now you're ready for the provider, and transfer you again to checkout. It's not just the video piece. So as we start to think about asynchronous, we're still going to do all of those things, right? We need to capture vitals. We might need to, have paperwork filled out and whatever consents and all those things need to be done. Maybe based on what you're describing, there's a series of we need you to provide these vitals, these self-reported vitals, and we want you to take a picture, or here are the instructions. We want you to take a video. We want to get a video physical exam of this. Here are the instructions. Do 1, 2, 3 and record that in a video and attach it, and really kind of put all of the information together so that the physician can make an assessment or diagnosis, and then sort of carry through to maybe any follow-up items, labs, or any of those things. So I think all of those things that fundamentally happen every time you go to a provider all of those steps are going to happen. It could just be asynchronous. So I wouldn't think of it as like, well, I'm having this email conversation back and forth. I think that's all in the context of one single encounter. And all of those things, all of those check boxes would still get checked off.
Matt, I love that you're thinking about it and bringing that conversation here to us. I can just appreciate how much our audience is going to enjoy this. Yeah. So one other angle to this that I don't think we've touched on yet, which has really been on my mind for some time now, is the whole idea of access, right? So we're doing telehealth because we think it's opening up access and giving access to diversity of populations and homeless folks and disadvantaged folks and people that can't leave the home, and make it more convenient for them. But the struggle is, as you and Stephanie both pointed out, that we still have a limited number of clinicians. The doctors on the other end that are providing the care are still a limited number of doctors, and they still have a limited number of hours in a day, 8, 10, unfortunately, many of them are spending 12 hours a day. I know friends of mine in primary care have told me they're spending, as you were saying, Matt, 4 hours outside of every day, every single day. They're spending 4 hours in addition to their clinic time to provide the care. So I'm kind of really been grappling with the notion of ultimately we have a fixed capacity in the system. How do we really expand that capacity? Is telehealth really opening up the capacity of the providers to provide more care? Or is it just a different modality of care, which is still another demand on them and ultimately another burden on them, which could just wind up becoming another way for them to get burnt out? So, I don't know, maybe a little bit of a bigger picture question, Matt, but I'd love to get your thoughts on how does telehealth really help us solve the access issue and ultimately the limited inventory or resources that we have?
Yeah, and I mean, you talk about access. So patients is definitely receiving better access to care, whether it's after hours. We've talked about shelters, all these different things. Even patients that don't speak English, right? You can have a virtual visit on demand. Provider can bring in a translator in less than a minute, and so I think for the patients, there's tremendous amount of access. When it comes to physician shortages and burnout, I think those are definitely big problems that we're thinking about. The Surgeon General came out this year and said, is warning about it, saying this is becoming detrimental to our entire healthcare system as a whole. So there are definitely other technologies that are trying to work to solve simplify the documentation. We're working with customers to simplify the documentation in a visit for a provider. But telehealth is faster. The average visit is about 7 minutes, and you can engage with the patient, but still have a lot of access to notes and the whole chart on your screen. So I think a big focus for us is how do we create those single screen experiences where you're always going to engage the patient, maintain good eye contact with the patient, but you still have all the data you need on screen. You can document a lot during the encounter, and ultimately the visits are shorter. So I think that's something that as we think about synchronous or asynchronous, we're always thinking about those challenges, and I think there is a lot that technology can offer, but that is a big problem, and that is something that as we think more digital and as we introduce more technology, okay, we need this technology to also mitigate some of these administrative burdens, which I think providers want. They got into this to help people provide care, not to type in a system 4 hours a day when they're done seeing patients. So that's definitely a big thing that we think about with our customers, and with any new solution, is how can we help with some of those problems as well.
To close this out, I'm going to bring it back to the warm and fuzzy And sort of what you were just saying, it's the patient or the doctors want to care for the people want the connection. So as someone who is leading a software organization, you guys are on the back end and you're providing all these different solutions. What is it like for you? What kind of impacts do you get that keeps you personally going, knowing that you're able to help make these changes and, bring that full circle, really?
Yeah, I mean, we don't hear about every story, and we know there's a lot more out there. But before the pandemic, I'll leave you with one story. We have Grace Medical Home in the area. They serve people who don't have any health insurance, that are at or below the poverty line. And we provided our technology to them. We donated our technology to them, and they were able to work with the state of Florida to get e-signature approved for the whole state. They were able to work with the county to get telehealth equipment funded and the FCC to get that funded. They were able to keep their doors open and provide care during the pandemic and see all their patients, and they still use these technologies. So we know that a lot of people are getting important care on our platform. And I wish we knew more of the stories, but that's why we started the company. We started the company to make an impact and do something, to be a part of the solution in healthcare to help solve some of these big issues. And we're definitely making progress every day towards that. So that's not only what drives me, that's what drives all of the employees here at Mend as well, to make an impact. Because Stephanie, you said it before the show, we're all patients. It's unavoidable. Even providers are patients. We've all been patients, and we're going to be patients. So there's just a tremendous opportunity to have an impact, and that's what drives us every day.
Thank you so much for being here and for this fascinating conversation. It was really great to play what the future looks like.
Great to be here. Thank you for having me, and this was awesome.
Well, thank you all for watching.
Yes, thank you.
Thank you all for watching. We'll talk to you soon. Bye-bye.